Thank you, everybody, for joining us. We're really excited to be able to have Dr. Saxena present for us today. Somebody with all his expertise and experience in using the AlterG is a really great resource, and I think hopefully everybody will get a lot out of this presentation. So just to give you a little bit of background, Dr. Saxena is a podiatrist specializing in sports medicine and foot and ankle surgery in the Palo Alto Medical Foundation Sports Medicine Department. He's been involved with AlterG since our very first start back in early 2006. He's been a fellowship director at his clinic, past president of the American Academy of Pediatric Sports Medicine, currently regional president of the American College of Foot and Ankle Surgeons. And you'll learn a lot more about his experience in the multiple type of patients and Olympians and athletes that he's treated. So we're really excited to have him today. Thank you so much, Dr. Saxena, for joining us and for presenting. And I will definitely let you take it from here. We'll leave time at the end for questions and answers. If anyone has any questions that pop up during the presentation, if you can just type them in the question and answer section, we'll be sure to address them at the end of the presentation.
Okay, well, thanks, Deborah and Mike, for having me speak for your group. We have a wide variety of people, from sales reps to therapists to doctors to coaches listening in. So I'm kind of trying to make it all user-friendly and understandable, that on levels that everybody should be able to understand and take home. And okay, well, there we go. So yeah, I was fortunate to have a trifecta of events happen in 2006 in January. Alberto Salazar called me about a runner named Galen Rupp, and then we had a continuous stream of Nike runners coming down, and that same month, within a week, the Whalen family, Rob Whalen is the founder, developer, and the patent holder of the AlterG, and they had known me, and they started talking to me about using the anti-gravity treadmill. And coincidentally, I was doing shockwave research, just initiating that with some German researchers. So it was just a trifecta of things that changed in my career that all worked out very interesting and fruitful. One of the things I learned from Alberto is that a lot of times people just try to go into denial mode with injuries, and people don't really get help or ask for help or start trying to address the problem early on. And so it's analogous to throwing out a life preserver. Do you wait and hold the life preserver while people struggle and tire out and then they can't be saved, or you try to recognize it and get the life preserver out there right away? So that's one of the philosophies I have when treating patients. Another one is basically similar to what Brooks Johnson, the famous track coach, has said, that if you take care of the small stuff, the big stuff will take care of itself. So attention to detail in caring for injuries, preventing injuries, no matter what sport, just like attention to detail and technique and anything you do is very important. So again, I try to use that philosophy in taking care of injuries. And the thing is, like with a lot of foot and ankle problems, people just say, okay, well, just rest or just put a boot on. And that's a knee-jerk reaction to people who are unable to come up with the proper diagnosis and or treatment plan. And so my saying is, if you're in a boot, nothing's torn or broken, you either need a different diagnosis or a different doctor. And just if you have an injury, you don't necessarily have to stop running. And one of the benefits about the AlterG is that you can continue to exercise and run to some degree while even you're recovering. So you may be healing still, but you're not healed. So you can continue to exercise and get some benefit from the AlterG, of which we all know is retraining and neuromuscular feedback maintenance is very important in any type of activity. So I've treated a lot of Olympians. First Olympian is 1988. I've been doing this for 32 years. And a lot of people are really scared of surgery. People term things as potentially career ending, and that is not necessarily anything that I would undertake a potentially career ending surgery on anybody. Most of the career, or most of the surgeries are career saving or career prolonging. So people need to readjust their mindset about surgery. And I've documented a lot of the procedures I do and their outcomes that are quite successful in the 95+%. I think you need to keep that in mind. And then there's a lot of people that go and get all these different treatments, and they are actually not helpful. Some cases they're harmful. So I would be aware of people offering things that are not proven evidence-based. Shockwave is one of the most strongly proven technologies and treatments for injuries, particularly for tendinitises, but we even, as I show, use it for stress fractures. And then anti-gravity treadmill is definitely a helpful thing, and it's being researched more and more. And then again, surgery is not a bad word. And I started tracking in 2008 what patients I treated that were in the Olympic trials, and how many used orthotics to get better, how many had surgery, how many used shockwave, how many people use anti-gravity treadmill. So just for interest to show how more and more people were using anti-gravity treadmills and other technologies for getting better. So here it is in 2012. And then in 2016, almost all the athletes used the anti-gravity treadmill that won medals at some point in time during their training. And so that's a trend that's obviously positive for the anti-gravity treadmill movement and substantiates it. So with running, a lot of people are running now because they can't get in their health club, they can't use the bike, they can't use the elliptical Stairmaster, so people are running more. So some things that have been proven is that if you do speed work in the morning, interval training, you're more likely to get injured. Concrete is harder than asphalt. And then overstriding is actually one of the most critical things that cause injury. It's not necessarily overpronation or oversupination, but overstriding actually is correlated with injury. And most joggers and early runners are running less than 80 steps with 1 foot per minute. The interesting thing is elite athletes have 90 steps per minute. And Galen Rupp, for instance, when I first started treating him, his average cadence was about 92 steps per minute. He was able to increase it to 97. So if every footstep is at 0.2 of a second, 5 steps is 1 second. 1 second per minute in 27 minutes of running, you would take your time, you would cut your distance that you run faster by 27 seconds. And so that was actually associated with his improvement from college to professional running, is just by learning how to increase his cadence. And so cadence is very critical. When you run on a swimming pool treadmill, your cadence isn't anywhere close to normal running. And even when you run on an anti-gravity treadmill, your cadence isn't close to running cadence outside. And this first study shows that cadence decreases with decreased body weight. So your cadence will be less if you're less than, say, 70% body weight. Imagine running on the moon, 1/6 your body weight. So you're taking these really long, bouncy steps. So that's an exaggeration, but that shows you that the less body weight you have, the slower your cadence is. There's another study that also shows that less body weight, your cadence decreases and your stride length increases. So that's one thing to be cognizant of, very critical, because people do get hamstring issues on an anti-gravity treadmill, and also with the new shoes that are Vaporfly type shoes. If your stride length increases, it puts more strain and stretch on your hamstrings, and that's why people can be prone to injury. So I'll talk about how we try to decrease that incidence. But again, if you can get your cadence close to a normal cadence on an anti-gravity treadmill by running between 70 and 90% body weight, you will train your body to run a faster cadence outside without body weight. And that's one of the ways that some elite athletes have been able to get faster. And so what percent body weight should you run at? So we know that you can be at 100% down to 20% body weight. The issue is that below 70% body weight and above 90%, what is being measured as unloading or reduction of body weight is not all that accurate. It can be a 5% variance above and below 70 to 90%. The other thing that we know is that when you run at less body weight, you have less VO2 max demand, and so you have reduced energy or oxygen consumption at lower body weight. So the benefit of that is that during your recovery runs, you can actually run at a faster pace, and you are training your cardiovascular system or your biomechanical system to run faster, but you're not stressing your cardiovascular system, your heart, or your lung capacity. And then there's different findings saying that you have reduced metabolic cost at different body weight or below body weight. Some findings show you have improved mood, which is very important because if people can't run or exercise, they do get moody or upset. So that's a benefit of having the anti-gravity treadmill. So the first injury we'll talk about, most common thing, and probably one of the most beneficial things for the anti-gravity treadmill is treating a stress fracture or dealing with a stress fracture. And yes, you can run with stress fractures, but it depends where the stress fracture is. Oftentimes you'll be resting anywhere from 1 to 12 weeks. 12 weeks would be for a very slow healing injury such as a navicular stress fracture that requires a longer healing time. But in other stress fractures, you can get back running in 1 to 3 weeks. You may need some type of boot for the first week, or some type of brace or casting, or just a foot orthosis. You definitely can use ice for pain and swelling because you want to reduce the pain and swelling before you start running. Now, the benefit of the positive pressure in the anti-gravity is actually pushes out the swelling, so that is a helpful thing. And then, yeah, you can start getting in an anti-gravity treadmill. The other things with stress fractures that people forget is addressing their biomechanic weaknesses or instabilities. Vitamin D levels very critical for stress fracture prevention and to heal. Your vitamin D level should be above 40 and even 50 in elite athletes in order to maintain optimum bone health and stress. So they should get, people with stress fractures, pretty much all of them should get a vitamin D check. And then we use bone stimulation sometimes for stress fractures and shockwave for some. And then there's surgery for certain bones. As I mentioned, the navicular is a slow healing one. And then Jones fractures are the ones of the fifth metatarsal that are slow in healing, and sometimes sesamoid injuries. So here's the first case of a very common injury. Tons of people, new runners, high school runners, elite athletes will get a lesser metatarsal stress fracture. So lesser metatarsal is basically the second through the fifth metatarsal, not the first, not the big one. But we're going to exclude the fifth metatarsal for this, and even the ones that are further back on the metatarsals, because those heal slower than typical ones. Most stress fractures are closer to the toes. And the typical treatment, someone would say, oh, you got a stress fracture, you have to rest for 6 weeks or more, and here, use this flat shoe, and here's a pad. Walking in a flat shoe will stress your arch more, or maybe your Achilles, so that's not good. Metatarsal pad actually increases the pressure underneath the bone, so that's not good. So what we do, or what I typically recommend, and have been spreading the word, is offloading the metatarsal with an insert. I'll show you how we do that. Cross train, and you can start running on an AlterG within 1 to 3 weeks, and you can get on a stationary bike and a pool almost immediately. And then you look at these imbalances and their shoes, their training, what do they do different? Vitamin D, and again, no anti-inflammatories, no non-steroidal anti-inflammatories. That means for any bone injury, you don't want to take any Advil, Aleve, Motrin, none of those. And this is a upside down pad, and for the second metatarsal, which would line up where that opening is, that's how you offload a second metatarsal stress fracture. So you build up underneath the first metatarsal and the third through fifth metatarsals. You can do this with duct tape or mole foam, and what you want to do is just temporarily offload that so that they can start walking pain-free and gradually start running again. So the next really common injury is shin splints, and there are a lot of high school runners who get shin splints. Their bones are growing, and you got to make sure it's actually shin splints. But typical treatment, people say, okay, just rest until it goes away and do some strengthening exercise like PT and orthotic devices, but not all orthotic devices are created equal, and I'll show you why. And So the sports medicine treatment is first make sure, is it a stress fracture? Is it a just shin splints where the bone lining is irritated? And again, high school and college kids will get that while they're growing because the bone grows like the rings of a tree, not only height, but in the circumferential aspect of the tree, and the tibia grows that way as well. It can be compartment syndrome. That is extremely rare. That would feel totally different than a stress fracture. Compartment syndrome gets worse as you run, but then it goes away within 5 minutes as soon as you stop running. And stress fractures, if you've ever had one, or shin splints, they can linger for hours or throb at night. So most people can run within 1 to 3 weeks of having a stress fracture or a periostitis. We take x-rays, but bone scans are helpful if you're concerned, really concerned, because MRIs will miss stress fractures. Orthotic devices need to correct for the forefoot. We use these pneumatic leg braces to help get them pain-free. And we use shock wave or sound wave. This actually is one of the most helpful things for stress fractures and shin splints. And then again, as we did previously, recommend looking with a physical therapist or trainer about imbalances in their shoes and training changes, surfaces, vitamin D, and avoid anti-inflammatories. So these orthotics, most orthotics end right at the ball of the foot, but the problem is when you run or when you play basketball, you do volleyball, any type of forefoot landing sport, you need to have buildup underneath the ball of the foot. So the orthotic for shin splints that are medially based, which are typically the ones you get, are built up on the medial aspect. And that makes a huge difference to people say, oh, I already have orthotics, so they didn't work. Well, if you add this on there, if they have medial shin splints, this will work like almost a miracle cure. And then the x-rays, if you rotate the leg, you can pick up stress fractures here. You can get MRIs, but a lot of times by the time you get an MRI, if a stress fracture shows up, it's too late. You've already probably cracked or broken the bone. So again, you want to throw out the life preserver early, get them off the impact, and get them on the anti-gravity treadmill, adjust the orthotic, use these leg braces. And if people are bow-legged, they will be more likely to crack it on this area. But that's the good area to break it because that's on the compression side, and bones heal with compression. These are the pneumatic leg braces that we use for stress fractures. You can use them for the fibula also, as well as the tibia. And then again, sound wave and shock wave actually is quite helpful. And so to run through this case, this is a gentleman who 17 weeks before the Olympic 1500 final had a full-blown tibial stress fracture. It was broken. 2 weeks of no running, just in a pool, walking with a leg brace, getting on AlterG at 2 weeks, and then from 2 weeks building up to 7 weeks running on the anti-gravity treadmill and mixing outside running, and got up to 90 miles a week. At 10 weeks, winning the Olympic trials in record time, and at 17 weeks, winning the gold medal. So in traditional treatment sense, he would have never even made it to the starting line, because if you have a tibial stress fracture, he'd be off of running for 6 to 12 weeks. So we did all the things I mentioned. We did the insert, we did the leg brace, we did the sound wave. He did sound wave quite often. You can do it actually almost every day if you can tolerate it, and the anti-gravity treadmill. Achilles issues are the most common in runners, and there's basically, for runners or people who need to run, there's 3 things that'll take them out of running permanently or lifetime. One is the back, second is the knees, and the third is the Achilles. But if you have access to an anti-gravity treadmill, and if you have access to shockwave and have access to a surgeon who, if you need surgery, which only 10% of the people need surgery, you don't have to stop running. You can get back running. And we have a group of international group of doctors from Germany here and Italy, and we've come up with some consensus about rehab of tendons. First one was Achilles ruptures, and what we found is that we had 100% consensus that on the anti-gravity treadmill, you can do bilateral heel raises at 50% body weight at 6 weeks post-op. You take the boot off, you still have the boot for walking around, but you get in the anti-gravity treadmill and start going up on your toes with 2 feet. And for insertion repair, it's typically at 8 weeks. And other soft tissue Achilles surgeries and plantar fascia surgery, sometimes you can start exercising at 3 or 4 weeks, or even in plantar fascia surgery, you can start running at 4 weeks. And so when you have Achilles tendonitis, you can actually run. The issue is you need to make sure you're at the 70 to 90% body weight and being pain-free. And you may have to put the incline up sometimes so you don't have the hamstring issues, which I'll talk about and discuss more. This is probably the first study on rehabbing with an anti-gravity treadmill that I published actually in 2011 with one of our PTs. We looked at our patients who had access to the anti-gravity treadmill, that basically the patients in our building versus patients who went outside to other facilities and tracked their healing time and return to activity. And we showed they got back running and exercising about 2 weeks faster. We also showed that if you can run for 10 minutes on the anti-gravity treadmill at 85% body weight, then that was sufficient to say, okay, you're cleared to run outside. So 2 weeks faster recovery may not seem like a lot, but just think if you're someone who's self-employed or you have to take care of your grandkids or whatever, not necessarily just a professional athlete, it does make a difference. The post-op protocols for any surgery are really important, and you can use anti-gravity treadmill basically for any weight-bearing lower extremity surgery at some point at the rehab phase. You just need to make sure your doctor and therapist or whoever's working with the rehab are all on the same page. You don't do something too soon. So patients need to adhere to the post-op immobilization timeframes. They can bike to start building up their legs with the heel and the pedal, even with a boot or a cast. They can run to the deep end of the pool, and then they start running on the, strengthening on the anti-gravity treadmill, then walking, and then running at appropriate time frame. And you have to coordinate this again with the whole treatment team. This is another article I published around the same time that showed return to activity timeframes and what you need to be able to do. So you can get these articles through PubMed or Google Scholar and request them that way. So I'm going to go through a case of Olympian, two-time medalist that had heel pain ever since he was in high school. And he'd had off and on heel pain. He had some Achilles issues. We were able to keep under control with shockwave and shoe modifications. He's had some injections. We generally don't like to recommend injections in the Achilles area. That really is needs to be under a very strict controlled fashion. He started getting more compensatory peroneal tendonitis because he'd had plantar fasciitis, and particularly while he was training with the plantar fasciitis, he developed the peroneal tendon compensatory problems from running more on the outside of his foot. And then he had a flare-up of his heel pain after a marathon in May of 2018. And again, we tried to keep him under control so he can train. And he was having problems in 2 sides of his Achilles and his peroneal tendons again, and his flexor tendon up till the marathon. And surprisingly, he was able to get through the marathon in 2:06, and he was limping towards the end of the race. And then afterwards, he swelled up and had a significant limp, and basically couldn't go up on his toes, which means he has a functional rupture if you can't stand on your toes on 1 foot. So we tried to do the anti-gravity treadmill. We did, but it just basically came down to decision whether he'd be training on this for most of his running or just bite the bullet and do surgery. So we decided to do surgery, and at 3 months, well, at 8 weeks, he started doing bilateral heel raises, and then he ran on a underwater treadmill for a week before he started trying to jog on the anti-gravity treadmill. And we allowed that at 12 weeks. So surgically, we did all the stuff to try to augment the healing with shockwave and PRP and the boot, and then using the anti-gravity for strengthening. And he started 12 weeks at 70% body weight and build up to progressive load up till about half a year. The other critical things is the rehab is with Achilles surgery, you don't want to do with certain surgeries, you don't want to do stretching. And the normal return to running is actually more than 4 to 6 months. Actually, average for average patient is 7 months, but elite athletes usually get back running in 4 to 6 months. So at 6 months, he was running about 40 to 50 miles a week after surgery, and running another 60 miles a week on the underwater treadmill. So the things you got to keep in mind when you're dealing with athletes is people talk about RICE or price. But I have a mnemonic called POLICE, where you want to do protection with the bracing or inserts, whatever you need for the condition. And then you want to have optimal loading. So that's when you want to introduce some kind of stress with something like an anti-gravity treadmill, stationary bike. Icing can still be used for pain and swelling. You want to address the core strengthening for any lower extremity problem, musculoskeletal problem that's activity related. You want to educate the patient, the coaches. You need to use evidence-based medicine, which is the highest level of medicine. And then you want to also address diet, because when these people are exercising, you need to be able to have potential to heal. And low vitamin D and not enough nutrition is a very significant factor in healing, particularly with stress fractures. And these are some screenshots of my website, which is up there, amolsaxena.com. And I'll send a PDF to Deborah, and she can forward it to you guys. And so with ankle sprains, you can pretty much get on an AlterG or in an AlterG right away. We start doing strengthening, and then usually, depending on the grade of ankle sprain, you start running between 2 and 14 days. Grade 3 ankle sprains are more severe, and high ankle sprains are more severe, so it takes a little bit longer. The metatarsal stress fractures that I showed, the distal ones are between 1 and 3 weeks getting back to running. And the slower ones, like the Jones fractures, are the ones more proximal, or sesamoids, they take a little bit longer to get back running. And just another screenshot. And then Achilles tendonitis or tendinosis, you can start doing strengthening right away. And if you're not having pain and swelling and limping, then you can start running on the anti-gravity treadmill between 1 and 3 weeks. And then with the foot surgeries, it depends on what was done. If it's a bunion surgery, like Paula Ratcliffe started running 6 weeks on the anti-gravity treadmill and was up to 100 miles a week at 12 weeks. So some people have an incredible rehab and healing potential and pain threshold. So you have to keep that in mind. Everybody's different. The reason why elite athletes are elite is because they're different. And this is another screenshot of the progression of running on an anti-gravity treadmill, and then blending in and feathering and outside running as well. So the first 2 weeks when you're rehabbing and getting back to running, you'll run on the anti-gravity treadmill for 30 to 40 minutes at 70 to 85% body weight. You can certainly start out with shorter amounts, like 15, 20 minutes. And then you feather in the outside running, and so you can get that off my website. And just some final thoughts. It's okay to do strengthening at less than 70% body weight. So as I mentioned, with some Achilles surgeries, we start bilateral heel raises at 50%. I just don't have people run at less than 70%, because you're probably not getting the benefit that you really could be. So Mother Nature has healing time frames, and you need to adhere to those. You can do hopping and squatting at less than 50% body weight, and then you should try to keep the incline at 2%. And that primarily helps you with overstriding. Has nothing to do with the theory about equalizing the lack of wind resistance when you're running on a treadmill. It really just has to do with keeping you from overstriding. If you have an Achilles issue, you might want to not keep it at 2% when you're above 80% body weight. At 70%, I would recommend that you try to keep it at 2%, but when you're at 80 to 90% body weight with an Achilles issue, you can just run flat. And then pretty much any injury or post-op patient can benefit from getting in the anti-gravity treadmill. I've had stroke patients learn how to walk better. So there's a lot of uses for this, and some rehab aspects and building up the hamstrings and glutes are running backwards on an incline at 3%. You can't fall off this treadmill because you got the gantry. And then you can add mileage with less impact, less cardiovascular stress, and do some tempo runs. I know a lot of high school kids, I have some friends who coach. I know a buddy of mine, Jeff Atkinson, who was my first Olympian I treated. He's down in Southern California, and he would have a group of high school kids go to a place that has it. They bring their homework, and someone would run for half an hour, another person run half an hour, and they just do group training that way. Of course, now with COVID, you got to separate that out a little bit. And then just be careful with the overspeed training because of the overstriding. You know, the runner I did that Achilles surgery on, and then he actually ran a 16-mile run at 92% body weight at 4:30 pace, and his hamstrings were really tired and irritated for about a week. So you can definitely, I mean, people who have a high pay threshold, they'll just keep running and run beyond their fitness level. And again, you have to use the best evidence. We need to use facts and data. We have clinical expertise. We have patient goals and coaches' goals and desires, and you need to use the research, and then we get the best evidence-based medicine that way. And so we have plenty of time. Well, I have until 1 o'clock for questions. So do you have any experience with patients that use lower extremity prosthesis? Yeah, amputees, they can use it for sure. So yeah, definitely. I just do foot and ankle surgery, but my buddies who do total joint surgeries that have used it find it quite helpful, particularly for knee joints, and people who have knee replacements and hip replacements can now run on the anti-gravity treadmill. We typically have them run at 70 to 70% body weight. Someone asked about increasing the incline. So there's a cost benefit thing. Yeah, you can increase your heart rate by going up at a higher incline, but you have to be careful you don't irritate Achilles. If any of you have had treadmill stress testing, they put you at 18% incline, and it feels like you're sliding off the back and you're really up on your toes. So you don't want to induce an injury by training too awkwardly. I've actually, believe it or not, had some patients develop injuries, including stress fractures on it, even while on an anti-gravity treadmill. And a lot of it is because they're trying to run faster and get their fitness back faster. And actually both those patients coincidentally were on oral steroids for trying to calm down their Achilles tendonitis. That's not something I prescribe, but a lot of people in their frustration, they prescribe high dose steroids to try to decrease the tendonitis, but you can weaken the bones with that, and actually you can induce a tendon rupture with that. And if they need surgery, you increase their chance of infection post-operatively. So steroids really, for a lot of these things, should be frowned upon for the most part and stay away from. It really has to be a select, very specific condition to be able to justify using that. Let's see, there's some more here. Yeah, are you aware of any metabolic equivalents? That article I referenced actually goes through that info. I'm not a exercise physiologist, so I can't answer that with a significant amount of intelligence. Yeah, PTTD is very common. It's called posterior tibial tendon dysfunction. I actually did surgery for that today. Most people, 70% of people don't need surgery. So people can rehab on the anti-gravity treadmill and start walking and exercise. So, and the person said, I mean, using amputee leg. Yes, so that's what I mean, a below knee prosthesis or above knee prosthesis. You can use the prosthesis and walk on the anti-gravity treadmill. So any other questions or?
Yeah, if anybody has any questions, please feel free to type them in now while we have Dr. Saxena here with us to answer them live. If you think of any after the webinar, please feel free to email them to the email that's linked to your registration, and we'll be happy to forward them along. But now's a great time to get, over the live discussion if you have any. I think we have one.
Looks like there's like a chat going on. We're all, oh, in terms of shockwave and AlterG, how to time it best. That kind of depends. You can use, use them simultaneously. I've had people, we sound wave them and they go and run on the AlterG. You can do it before, you can do it after. You have a concurrent, that Olympian that won the gold medal in the 1500, he was sound waving and then getting on the treadmill. He was using it 2 to 3 times a week sometimes and training 90 miles a week. If you have an injury that has not healed sufficient to get on the anti-gravity treadmill yet, then go ahead and do the shockwave. And Karsten is one of the world's experts on shockwave. You can listen to his webinars. He's much more animated and motivating than I am. So pros and cons of the pros and cons of AlterG training versus pool training. Yeah, so pool training, when you're in a pool, you only reduce your body weight for 20% at the, and you can't increase it really more unless you add a backpack with weights in the pool. And your stride, again, if you can get your cadence as close to normal running, or ideally with the anti-gravity treadmill, get your cadence going at what you do outside, your cadence will improve outside. So I think that's very important. When people run in the deep end of the pool, their cadence is also a little bit increased as well, but it's not, your body isn't getting stress at all. So the neuromuscular feedback, I think, is different. Of course, that probably needs to be proven in some type of research, but that's my gut feel, is that when you run to the deep end of the pool, the stresses to your body are not the same. And Brooks Johnson used to say, you get your cardiovascular system more fit than you get your musculoskeletal system. So there's a disconnect, and you need to have those systems all firing in synchrony.
Great. Now we'll see if anybody else has, oh, here we go. Why makes you decide at 70% body weight on AlterG?
Why? Well, initially it was personal experience, and your body parts and your where the air pressure pushes on are uncomfortable to run sometimes at below 70%. Your foot is more pointed or plantar flexed when you're at less than 70%. So your mechanics, your foot strike are different, and your cadence is significantly slower. And but then now that's been proven in research with those 2 articles I showed you, at least that first one, where 70 to 90% is your cadence is more closer to normal. So I typically don't recommend people to start running until they can hit 70%, but you can do other strengthening and things like that at less than 70%. Karsten, with the Vaporfly. Yeah, so if you wear the Vaporfly and the AlterG, you're going to be really overstriding. So you might have to put the incline a little bit up, and then if you put the incline up, you might have to watch out for your Achilles. So, the reason why people run faster than Vaporflies is because their stride length is longer with those shoes. So, so yeah, just be very cognizant of hamstring issues.
And we have a question about finding facilities that offer the opportunity to use and train or rehab on the AlterG in California. We do have a locator on our website, the AlterG locator. So if you're ever interested in seeing which facilities, clinics, we have a variety of different settings that they could be found in. The AlterG locator, again, is right on our website. If you type in your zip code,
and that works internationally, because Stefan and Karsten are both in Germany.
I can definitely
so that
check
works
on that. Yeah. And actually, Stefan, I will be in touch and be able to give you some more information on how to to find out any that are in Germany. But I know for sure, obviously, the US locator works, and I can get back to you with how to find all the international sites as well as connecting you with our distributors there who have close connections with all the customers in your countries. All right. Well, if anybody has any other question, this is the time to type it in. If not, just to let you know, we will be sending out the recording. So if there's any part of it that you missed or just want to review, we have recorded today's webinar, and we will definitely be sending that out in a mailing that will go out first thing in the morning. So look for that. And again, if any other questions come up, please don't hesitate to email them to us. Our email that you can send them to is right on your registration email that you received when registering for this webinar. Dr. Saxena, thank you so much again for presenting all this great information to us today and for hosting such a great webinar.
There's one more question in the chat. Does cadence make a difference in casual runners? Cadence makes a difference in all runners. So it's important. It's probably even more important to train your casual runners to get the cadence up. So someone who's totally new to running, a good way to train them to running is have them come in and run on the anti-gravity treadmill and progress them from 70 to 90%. So, and again, a lot of high school runners or triathletes that are trying to add mileage or increase their cadence, they do part of their training on the anti-gravity treadmill, even if they're not injured. So, and that's actually a good way to pay for your AlterG, is not to just expect just injured people to use it, but to have people who are maintaining fitness. There's some physical therapy groups in our area that just charge a monthly fee, like a club fee, and then they can come in and use the anti-gravity treadmill. So.
Wonderful.
Okay.
Awesome. Well, thank you again. Thanks everybody for participating. We are excited to continue to host more webinars such as this one with great information and experts and who have such great expertise in using it for a variety of treatments. So thank you again, Dr. Saxena. Thanks everyone for participating, and have a great rest of the week.
Okay, thank you.
Thanks. Bye-bye.